Thank you so much. Thank you everyone for coming. So I will be taking you through an overview of digital public goods in Africa. We'll do a brief introduction of what digital public goods are, a summary of what digital public goods standards are, and I will take you through the various implementations of digital public goods around the region. So I'll begin by introducing what digital public goods are, and they are four key things. So they can be open source software, open data, open AI systems, and open content collections that adhere to privacy and other applicable best practices to do no harm by design and are of high relevance for the attainment of the United States 2030 Sustainable Development Goals. So I think we're all aware of what digital technologies are, but there's a description on the edge of the slide where it's the electronic tools, systems, devices, and resources that generate, store, and process data. And then public goods are commodities and services that are provided without profit to all members of society, either by government or private individual and or organizations which are to the benefit of the well-being of the public. So the concept of digital public goods derives from the term public goods, which refers to something that's non-excludable, which means you cannot prevent someone from using or consuming that good, and non-rivalrous, which means that consumption or usage does not limit or take away from someone else's already existing technology. So in the next slide, we'll go through what digital public goods standards are. And the standard is basically designed to maximize the consensus about whether a digital solution conforms to the definition of a digital public good. So it establishes the baseline, the foundation and the fundamental requirements that must be met in order to earn recognition as a digital public good. So the standard is designed to complement other relevant principles, such as the principles for digital development, and is applicable to all digital public goods in all sectors across the Sustainable Development Goals. So once a software or a tool is recognized as a digital public good, it is discoverable and registered on the Digital Public Good Registry. So as I mentioned, the digital public goods standards are a set of indicators and requirements that operationalize the digital public goods, and there are a set of 9 indicators that are used to determine whether or not a solution is a digital public good. So the 9 indicators are relevant to sustainable development goals, use of approved open source licenses, clear ownership of the product, platform independence, documentation, adherence to privacy and applicable laws, mechanisms for extracting data, adherence to standards and best practices, and of course, a do no harm design. So we have to look into data privacy and security, inappropriate and illegal content, and protection and harassment. I think in the conversations in the digital health world, you will hear global goods and digital public goods being used interchangeably. So I thought it would be important for me to highlight these slides just to show the differentiation. It's very minor, but it's important for us to be aware of it. And I think something that I would want us to take away from this discussion is that all global goods are digital public goods, but not all digital public goods are global goods. So in the Digital Public Goods Registry, there are 151 registered digital public goods, and 79 of them are registered under the SDG 3, which is for good health and well-being. So global goods can be considered mature digital public goods, and maturity speaks on the metrics to understand how advanced a tool is. So global goods differ from digital public goods in that they exclusively focus on SDG 3 and are primarily implemented in low and middle income countries, while digital public goods focus on all the 17 SDGs. So in this slide, I will be highlighting the benefits of using digital public goods. So one of the benefits is that they have the potential to promote economic development and address the digital divide by reducing monopolies, powering startups, and promoting innovation in the public and private sectors. And then open source tools offer more control and independence, as well as the opportunity to build capacities and trust through agency. And of course, digital public goods reduce the risk of vendor lock-in, where customers are unable to switch providers or developers because there's a cost element to it. and provide a greater adaptability and responsiveness to the changing needs, making it easier for countries and communities to make strategic decisions and take a long-term holistic perspective when building their digital foundations. So these benefits just highlight that digital public goods are so important and will be so relevant for countries and organizations and institutions that are interested in starting their digital transformation journeys. They will form a very good foundation to build upon. So digital public goods in Africa. So WHO statistics show that 23 of the 27 countries in Africa are ranked as low and middle income countries are in Africa, and 21 of the 55 countries ranked as low and middle income countries are in Africa. So that these statistics just describe that Africa provides such a robust ecosystem for digital public goods to be implemented, because it's already an environment that has not been tapped into, that digital public goods could be implemented and thrive in. So this next couple of slides just gives an overview of the digital public goods that have been implemented around Africa. So I picked and chose a few that represent some systems that are managing some health system building blocks. So we will go through a couple that manage laboratory management information systems, others are supply chain centered, others are insurance centered. So I picked and chose a few examples just to highlight what's happening around the region. So we have OpenInmis, for example, and it's a versatile tool for managing health insurance and social protection schemes, and it has been implemented in 8 countries around the region. And then we have DHIS2, which I think is one of the most popular digital public goods, and it has been implemented in 46 countries around the region. It's a web-based platform for managing both aggregate and individual level data. And then we have RapidPro, implemented in 28 African countries, a system for managing interactive messaging. So it's been used by countries to manage their health promotion messages and their health facility reporting, and to standardize campaigns. So for example, in immunization campaigns, it has been used. And then we have Open Concept Lab, implemented in 6 countries around the region. It's a tool for health terminology management, and it has been used to develop the national data dictionaries for various countries, for example, Kenya. And I think Kenya was the first country where Open Concept Lab was used as the foundation for building the national data dictionary. And then we have OpenMRS, again, one of the more popular digital public goods, implemented in 19 countries. It's an EMR platform, as well as BAMNI, which is implemented in 23 countries. So they are both electronic medical record systems. And then we have OpenFN, implemented in 16 countries, which is a workflow, an automation tool to securely automate business processes, exchange critical information, and achieve interoperability. And then we have OpenSRP, which is a mobile health platform that allows frontline health workers to electronically register and track the health of their entire client population, implemented in 13 countries around the region. The next slide shows the Global Open Facility Registry, which is a facility registry platform implemented in 4 countries, which are Ethiopia, Liberia, Sierra Leone, and Tanzania. And ISO, which is also can be used as a facility registry solution, implemented in 8 countries. And the next slide is just highlights systems that have been used for logistics management. We have Open Boxes and we have Open LMIS. Open Boxes has been implemented in 5 countries. We have it in Liberia, Madagascar, Malawi, Rwanda, and Sierra Leone. And Open LMIS has been built in and implemented in 13 countries. Then we have a tool for managing human resources known as IRIS, implemented in 20 countries around the region. It's used for managing human resources. And then we have Open ELIS, implemented in 3 countries. It's an enterprise level laboratory information system. So that, I think, just gives a very general picture of the landscape in Africa and how digital public goods are implemented. And I hope it gives you a sense of how vibrant the communities are and how ready we are to begin our digital transformation journeys. So thank you very much for your attention. Over to Sha. Thanks.
Thank you, Dr. Sylvia, for giving an orientation and an overview of the GPG. So I'll I requested her to do that earlier, so I won't have to do it. Thank you, Dr. Sylvia, for that. And that allows me to focus on the Asian component, and also to mention some of the Sri Lankan global digital public goods, but also give a chance for Dr. Chaminda to tell you more about that in detail. Okay, so this would be a subset of what's in the global digital public goods for health that we know are being used by countries in Asia or by the Asia eHealth Information Network community of interoperability labs. So Dr. Sylvia already mentioned this document. It gets updated frequently, and the last version, version 4, was released last May. So if there were any additions of Asian countries after May, we may not be able to see that in my presentation, but please feel free to contact me and let me know so I can add your digital global public good to the list. So first in the list is Open EMIS, or Open Information Management Information System. It is a open source health insurance management system used in Nepal and Tanzania. In the Philippines, because we already have a robust health insurance system with the Philippine Health Insurance Corporation, we are using Open EMIS in medical education to show students the concepts of health informatics and health financing and how they are tightly interlinked with each other. That to get good health financing, it's important that you have very good health informatics. DHIS2 has been a very popular and active member of the Asia eHealth Information Network as far back as our first meeting in Bangkok in 2012. This is just a short list of countries in the whole world that are using DHIS2. This is their website. And if you click on their communities of practice and impact stories, then you would see stories from Nepal and Pakistan, from our side of the world. And I know that Dr. Chaminda will also mention something about the HIS2 in his country later on. SORMAS is the Surveillance Outbreak Response Management and Analysis System. We have been contacted by Dr. Pilar about the SORMAS, and we are scheduling a session where they can talk more about their experience and also gather their clients from the ministries of health who can also provide insights on the challenges and the benefits of implementing an open source software like SORMAS in their countries. This is their website, and this is a list of the countries Dr. Pilar just provided me before this talk. And in this list, we have Fiji and Nepal. OpenCRVS is an open source software solution for civil registration designed specifically for use in low resource contexts. I am pleasantly surprised that the Philippines was listed here. So I will be reaching out to the team at OpenCRVS and find out how we can collaborate with the Philippine team implementing OpenCRVS in the country. I think this is one of the components that are missing in terms of the Open HIE, or Open Health Information Exchange interoperability framework. OpenCRVS might serve as the client registry for an Open HIE implementation in the Philippines. Rapid Pro is an open source platform allowing anyone to build interactive messaging system. They have a lot of implementations in Asia, Vietnam, Bangladesh, India, Myanmar. Open Concept Lab is a health terminology management system. I know that they have this in Sri Lanka. Sri Lanka is listed here at the bottom, Bangladesh, India. So I hope we could learn from the Sri Lankan Interoperability Lab, to which Dr. Chaminda belongs to. They are using Open Concept Lab, while our lab in the Philippines and in Thailand, we're using Onto server. The Android Fire SDK is one of the more recent digital public goods that appeared in the list. It has Indonesia in the roster, and so we are presenting it right now. We hope to link up with the Digital Transformation Office, or the BPJS, and I think I saw Rudy earlier today. Maybe we can ask him during the open forum if they are using this extensively right now or just preparing for its implementation. The Community Health Toolkit is a digital public good supporting health workers as they deliver care in their community settings. It has India, Nepal, Philippines as Asian countries using this. OpenSRP is short for, I forgot the SRP, but this is a platform that allows frontline health workers to electronically register and track the health of their entire client population. So here we have Thailand, Indonesia, and Bangladesh. And the group that has built this, ONA, and Mr. Matt Berg, has reached out, and I think there will be implementation soon in Jakarta and in the Philippines. OpenFN is a workflow automation tool used by governments and NGOs in 40 plus countries. The ones listed here are Bangladesh, India, Indonesia, Myanmar, Philippines. So we have a lot of implementations of OpenFN here. What we plan to do after this webinar is to contact each of these global digital public goods and request them to inform their Asian implementers to fill up the Digital Health Atlas. And I have a slide on that later on. Sante MPI is a proven next generation, fully featured master patient index or client registry along the lines of the OpenHIE client registry. I know Joseph Dalmolin and Justin had implementations in Myanmar, and I hope that we can have a session later on from the MOH team in Myanmar and Sante MPI team on their experience with implementing this. BAMNI has a lot of implementations in Nepal, Vietnam, Cambodia, Indonesia, India. It's an open source hospital information system and electronic medical record. If I remember right, there was a hospital in the Philippines that implemented this. It had Open ERP for ERP, Open MRS for the electronic medical record, and two other open source applications that they put together into the BAMNI suite. DIVOC, or Digital Infrastructure for Verifiable Open Credentialing, is an open source platform that enables countries to digitally orchestrate large-scale health campaigns such as vaccinations and certification programs. So we have these in India, Indonesia, Philippines, and Sri Lanka. Everwell is a patient management platform designed for high-burden public healthcare programs globally. Asia, we have Bangladesh, India, Myanmar. OpenEyes is a specialized open source electronic patient record for ophthalmology. In Asia, we only have Pakistan for implementation. Maybe if Dr. Mursalin is in the call, we could get more information about who are the implementers of OpenEyes in his country. OpenMRS is one of the earlier open source electronic medical records. We have implementations in the Philippines, India, Indonesia, Pakistan, and Sri Lanka, Vietnam. So in the Philippines, it was repackaged as CHITS, or the Community Health Information Tracking System, by the University of the Philippines, Manila. This is their interface. It's running on OpenMRS version 2.0. It is used in 140 plus frontline health clinics in the country. And I think they're moving to interfacing this with the Consulta package and the electronic claim system of the National Health Insurance Program. I think that's the next challenge for the global digital public goods, which is to demonstrate interoperability with other digital public goods. Tamanu is a free and open source patient-level electronic health record for desktop and mobile. We have them in Fiji, India, Kiribati, Nauru, Samoa, Tonga, Tuvalu, Palau, Papua New Guinea, mostly in the Pacific Island countries. Open Clinic GA, Integrated Hospital Information Management System, covering management of administrative, financial, clinical lab, X-ray, pharmacy, meals distribution, and other data. For this, we have in Asia, India. I think that is the only Asian country, and Vietnam. The GeoPrism Registry is an open source common georegistry implementation that utilizes spatial knowledge graphs to provide a single source of truth. We have it in India and in Laos. GNU Health is a modular extensible hospital information system using open source tools. We have this in Bangladesh, Indonesia, Laos, Malaysia, Pakistan, and the Philippines. IRIS is for use by ministries of health for their human resource information system. We have India, Laos, Nepal, and Pakistan as implementers. OpenELIS is an enterprise level laboratory information system used right now in Vietnam in Asia. OpenLMIS is a powerful cloud-based electronic logistics management information system used right now in one country in Asia, Nepal. Comcare is a digital data collection and service delivery platform designed to improve data collection and the quality of frontline services in low resource settings. A lot of Asian countries listed in the roster below. ODK was heavily used also in the Philippines during the COVID pandemic. It was very quick to deploy, and it was giving information to the ministry or the Department of Health on the availability of scarce resources in the different parts of the country. Reveal is a global public good that enables country governments and implementing partners to use geospatial technology to plan and deliver life-saving intervention campaigns. So we have this in Thailand. Tupaya is a data aggregation tool for analysis, visualization, mapping health systems in LMICs. It is used to complement other systems such as DHIS2 and mSupply. We have this in Fiji, Kiribati, Laos, Marshall Islands, and most Pacific Island countries. VXNAID is in Mali, Philippines. It integrates innovative technologies to improve patient tracing, data management, and communication to implement impactful vaccination campaigns in low resource settings. Just to end, in the annex of the global public goods, they have descriptions of some important public good that are not specifically software, but are very important foundations to the digital public goods, such as OpenHIE. So if you go to wiki.ohie.org, you will see more about this framework. This is so important to AHIN that we partnered with the OpenHIE community to offer a certification reimbursement program to our members. So if they take the certification and if they pass, we are reimbursing the cost of their certification. This is to encourage them to study and to take their certification on OpenHIE. This is in preparation later on for a larger program of expanding a workforce that is knowledgeable about interoperability in the region. These are the numbers of certification passers in the past 2 years. We hope to offer this annually to more people in the subsequent years. This is not specifically a global public good yet, but the AHIN members, about 100 of us took this course and we learned a lot here. The course is free through a partner, and we were blessed to have a support from WHO, USAID, Patrick McGovern, to send a cohort of 100 people in this course. There are a lot of standards being used in Asia. This is just a short list. HL7, Fast Healthcare Interoperability Resource, the International Patient Summary component of that standard, ICD-10, ICD-11, LOINC, SNOMED, and OpenEHR. In the Philippines, these are the things that are in action. OpenMRS, HappyFire, AutoServer, WHO Smart Guidelines, Sushi Fish, GitHub Implementation Guide, Empty Template, and the Academy ohie.org. And these are the ones being used in New Zealand. We have 9 interoperability labs in the AHIN community of interoperability labs, that only 3 are participating tonight. And I'm happy to pass the floor to Dr. Chaminda before my last slide to say to the implementers of the Digital Global Public Goods, I encourage you to register your project in the Digital Health Atlas so that next year we can just use this to monitor which the digital global public good is running in which country. Thank you very much. Dr. Chaminda, the floor is yours.
Thank you very much, Dr. Alvin. Thank you very much, Dr. Alvin and the AHIN for the invitation. So I'm going to talk about the digital public goods in Sri Lanka. So because it's Africa, Asia region, audience, I would like to, first tell you a bit about Sri Lanka. So Sri Lanka is in the Indian Ocean, and we are an island nation. And we have about 22 million population, and we provide free healthcare at the point of delivery, and the state health sector provides most of the care, like 90% of in-ward care and 50% of outpatient care through 1,085 odd state healthcare institutions. And we have achieved a lot with limited spending on health, with just 3.5% of GDP. We have eliminated malaria, filariasis, polio, rubella, measles, because we have a very good public health system in the country. And we have relatively high life expectancies as well, and other indicators. So I'll not dwell through the digital public health goods standard because this has been discussed, and you can find the full registry with that 151 odd solutions listed through this web link. When it comes to Sri Lankan implementation, we have a very vibrant community of DHIS2 in Sri Lanka, and so many DHIS2 implementations as well. And recently, we and also Moodle. Moodle has been there for a long time in the education sector. But in recent times, we have started a project on Open MRS, and we have started using Open Concept Lab. And for COVID vaccine certificate issuance, we have integrated IVOC with DHIS2, and it is currently being used for COVID vaccine certificate program. And we also have a couple of other solutions in the pipeline. So OpenSRP with another research project actually in the country. And Sunbird RC, which will support our National Electronic Health Record linked registries. If I were to go through some of the more prominent DHIS2 instances, so this reproductive health, maternal, neonatal, child, adolescent, and youth health program, it's a very structured, paper-based for information flow, even before we started the the digitization of those workflows. So there's a very good structure in the community. You have the community health workers which report to a medical officer of health area, then get reported higher up to the regional or the district level, and then the provincial level, and information flow directs the national vertical campaign, which is the Family Health Bureau, which looks after this maternal, neonatal, child, adolescent health. So they developed this DHIS2 based information system, and they almost it's 100% nationally implemented, and the full workflows are now fully digitized. You don't need paper-based information. And also recently they moved on to individual-based data using Tracker, So they call it ERHMIS version 2, and that's been implemented through the Family Health Bureau. I think I have to tell you in advance, so I'm not directly involved in any of those DHIS2 instances, but there are a lot of health informatics professionals in the country who are engaged in day-to-day management of this, DHIS2 platforms. Then during the COVID times, we started this national COVID-19 surveillance system. I was actually trying to play a video, but I couldn't, get it arranged. This was about the development of the COVID metadata kit by the Sri Lankan DHIS2 community, which was then globally adopted, and the speech by the Prime Minister of Norway, she was stressing about, how that helped most of the countries which are already having DHIS2 capabilities quickly set up their national surveillance systems using that metadata kit. And with time, the immunization came, and then we managed to set up a COVID-19 immunization tracker. So this is patient-based, and now connected with the DIVOC, we issue digital COVID vaccination certificates to anybody who wishes to, go abroad mainly. So these are quite these were quite challenging, I would say. This immunization tracker, when we set it up, we managed to get hold of all the demographics from actually the election office of Sri Lanka. They were they shared with us that detail. So 15.6 million odd records were update. Sent to the DHIS2 instance, and with the Oslo team, we did a lot of optimization on the the DHIS2 platform to handle that much of data, and that actually helped us a lot in expediting the data entry and issuance of these certificates as well. And then we have injury surveillance system using DHIS2, and then immunization system using the DHIS2 as well. Mental health, aggregate data collection, district nutrition management system, which is a sort of aggregate information as well as tracker-based information on nutritionally deprived children in subnational level. And then we have even non-health interventions like the education management system and cross-sector collaboration for nutrition under the Presidential Secretariat. The last one actually is not functioning anymore, but then they were there for some time, and newer systems have sort of replaced them, currently. One of the important things about the DHIS2 capacity in Sri Lanka is like with Norwegian Master's Program, or NOMA program, with Norwegian Agency for Development Cooperation, NORAD grant, that was received in 2008 by the Postgraduate Institute of Medicine in University of Colombo, Sri Lanka. They started this program in biomedical informatics for doctors, and that program was actually was a collaboration between University of Oslo and the Postgraduate Institute of Medicine. So there was this very close link between the two organizations, and the DHIS2 was actually a part of our curriculum in the program. So everybody who got out of that pipeline were very conversant in DHIS2, and when they entered this Ministry of Health Service, they went and set up multiple DHIS2 instances for multiple vertical campaigns for public health and other administrative units in the Ministry of Health. And through this collaboration, we have now a few international trainers as well. Along with this, the large group of practitioners in DHIS2, we have set up these WhatsApp groups, training sessions, gatherings, and this community of practice in Sri Lanka, along with its link with the Oslo University, and also some of the developers being stationed in Sri Lanka as well. We are quite placed well to leverage on DHIS2 for many health, public health, data collection, implementation. So I think this has made the Ministry of Health very reliant on DHIS2 as well, and also very confident that we can do a lot with our own resources. We don't have to basically wait for international support to come and help us implement DHIS2 in the country. So that's a very interesting case, I suppose, not seen in many other places. And the OpenMRS, it's also not new. When I was following the master's program, we had a visit from the HISP India, who came and taught us on OpenMRS, but during that time, some of the features were not very well aligned with our health system, but we have seen it has improved a lot in the past, and now we have adopted the OpenMRS system to be modified as a cluster information system. Basically, you have one large hospital that is actually catering to smaller hospitals. So the project, which is called HSEP under the ADB Bank, they want to transform the health system in the rural areas, and OpenMRS has been the choice, and they wish to give the services of larger hospitals to the smaller, the peripheral units through this cluster information system, and want to give all this, the elderly care, family planning services, and all of that integrated with the health information system as well. So this has been outsourced, and I was very glad to meet Grace and the team, OpenMRS team at OHI 23, and we actually found out that their QA team is actually based in Sri Lanka, and we have made good connections and collaborations with them. So we can actually, leverage on their expertise when we set up the system in Sri Lanka. So that is one very plus point I can say about the OHI meeting we had last May. Then the Open Concept Lab, we have set up an instance in the Ministry of Health, and the idea is we are setting up a national electronic health record, and to ensure the semantic interoperability, we want to have the standard vocabularies or terminologies used, and with the help of the OCL community, we managed to set up a local instance. But I think on the long run, we found out like it's easier to manage the different value sets in the OCL online, because you already have the other terminologies installed in the OCL online. And once we create those value sets, we might mirror it in our local instances and made it available to the National Electronic Health Record or EMR users. And Moodle again, many medical faculties in the country are using Moodle for undergraduates as well as postgraduate training, and also we have an in-service training platform because we train the paramedical staff through the Ministry of Health Education Training and Research unit. And during the COVID time, like everything had to be stopped, and then this vital paramedical staff could not be trained and easily absorbed into the service. So like within a couple of weeks, we managed to set up a Moodle instance, train the trainers again through the Moodle, and almost replicate all the most of the programs in the digital sphere and start their training and ensure that the continuity of training is there. So open, so the Moodle being easy to install, customize, and as well as having prior experience with the being working on medical during the the undergraduate studies, we managed to quickly set it up and start training and restart those paramedical services. And in the future, as I said, we have a sort of a research done by supported by the World Diabetic Federation to screen people for NCDs in the community, and then connected with the existing electronic medical records as well as the DHIS2 instance for monitoring, capturing those monitoring indicators and running the program. So that part we are currently doing, and we had a couple of connectathons, and it's in sort of final phases of implementation. And we are also in collaboration with the Sunbird RC from India. They have experience in setting up this facility and provider registries in India for their Aadhaar program. And they are helping us customize them for the local needs to be incorporated in NEHR. So basically, I think in summary, like there are many digital public goods across many sectors in Sri Lanka, and one of the major things that we see as to its success is we have developed local capacity in these DPGs, and that helps us a lot in sustaining these interventions. And we also keep good connectivity with the global communities that helps us manage them, and also there are many in the pipeline for Sri Lanka. So thank you very much. If you have any questions, I'd be glad to answer. Thank you.
All right. This is Stephen. Thank you all very much for the presentation. Yeah. So thank you very much. I know we've probably about 12 minutes, and I have the privilege to help moderate the open session. As Dr. Alvin typed in the chat box, please feel free to either raise your hand, if you'd like to comment about any of the presentations made by our presenters. So thank you very much to the four presenters. A couple of really interesting comments have come up in the chat box, and I'm just going to pick up a few that I think are really interesting. Some of them, for example, Dr. Alvin has mentioned a few times about the need for us to really work together, particularly to solve the perennial challenge of interoperability. So the adoption of global goods, I think, global public goods, as we've seen both in Africa and in Asia, is pretty high, but we also don't know how high it is because we don't have the real numbers. So as Dr. Alvin has mentioned, please enter your implementations in the WHO managed digital health atlas. That really help us to understand the digital health interventions within your application, but also more importantly, help us to learn a lot more from each other outside these joint sessions that we are having across the two continents. So that's one. But I think a couple of other comments that I'm seeing here also have to do with evidently there isn't as much knowledge as I think we might want to assume about global public goods. So I think we need a lot more of these sessions. I've seen a couple of really interesting questions about open source. I actually thought that maybe digital public goods is a very common concept, but looks like we need to do a lot more of that ourselves in our countries, in our regions. And I think that goes to show that we need a lot more of this, and we should look for many more opportunities to do that. There are a couple of questions also, I think, to do with what it actually costs. What does it actually cost? Many studies have been done on a concept called total cost of ownership. But I think more importantly, beyond the academics of determining cost of technology and health information systems, would be nice to hear also from implementers what that actually means to them. What costs are they incurring, and how are they dealing with those costs? But yeah, I don't talk too much because I know we've been listening a lot, and maybe some people have very, very burning questions to some of the presenters. So any of my co-moderators could help me if you can see any hand up, and we can give the audience a chance to either speak up, or if you'd also like to highlight something I've not picked up from the chat as well. Alvin, did you see anything interesting in the chat?
Yes, Stephen, to Dr. Aminul Islam from Bangladesh, he said that he's very interested and he is hearing some of the implementations in Bangladesh for the first time. Dr. Aminul, maybe you can say something about the work that you're doing, and then maybe we can ask the other people to help out to fill out the information that you're asking for in Bangladesh.
Thank you, Alvin. Thank you very much for a nice presentation. I learned a lot from you and other presenters. So basically, there are a lot of systems. There are a lot of open source platforms exist, but in Bangladesh, I personally know that DSS2, one of the main systems that is implemented is larger scale, and it is one of the successful projects in Bangladesh. But OpenMRS, in the implementation phase, it is not up to that much, because in the user end, the doctors and health professionals are not using the systems because they're saying the system is not user friendly and they're going to do what they wanted to do. So that does not reflect the system. So you mentioned that one system like ComCare, but I never heard that Bangladesh is using, where is using, how much is using. So if you have something like, so the systems that is using different countries and what extent they're successful or not, like maybe 50% using the user end user, or I mean, this type of data will be helpful. And if we know that what are the challenges from other country to implement the system, because system is there are a lot of open source system, you have already ready system, but there are a lot of things that you need to contextualize country to country. So, and Bangladesh is facing, for example, OpenMRS. Mainly Bangladesh is using Bomni, you know that. So, but in the user level, I know several hospitals that they are using OpenMRS Bomni version. They are only using like ticketing, registration, and appointment. Mostly they are not using any, I mean, the e-prescription or pathology or radiology or other systems. So they are struggling to cope with the OpenMRS. So it would be good from AHIN if you have some statistical data from different countries. So the challenges and the level of maturity or level of acceptance from the country to country perspective. So that will be very helpful. And you already mentioned that to so introduce me. I'm a health informatician. I completed my master's from Karolinska Institute in health informatics, and then 2015 I started working as an assistant professor in Department of Health Informatics, University of Health Science. And besides, I'm working in different organizations as a consultant. I have completed 5 hospital digitalization projects. It's one of the big projects in Bangladesh, and it was so much challenging to implement, basically in the end user level. So system is there, but users are not ready to accept the digitalization process, especially
Thank you.
Professionals. Thank you. So
Thank you, Dr. Aminul.
If you could little bit describe my question, and I'll be happy. Thank you.
I'll share you my slides by email. Thank you. Stephen?
Thank you. I see Edwin's hand is up. Edwin, do you want to get off mic, mute, sorry, and speak?
Yeah, thank you so very much, Steve, and thank you, Alvin, and other presenters. Thank you for the information that you shared with us. It's quite very informative in terms of the public goods that are there, but also the areas where they're being used. And just my comment, of course, in Tanzania, we have quite a number of open source public goods that we are using. Namely, the OpenSRP is currently having a very good uptake when it comes to the community level and the linkage between the community and the facility. My comment is on the first, in terms of the capacity building behind these tools, especially I find that like some of these tools, they do have a very limited number of people that are quite good at them, like the OpenSRP itself. When I look at it, those that are really quite good at these tools, they're very limited in numbers. So I'm looking at if there are some forums where, you know, there's a possibility to build capacity so that you can have quite a good number of people that are handy when it comes to implementation of these systems. And also, if we do have if there's any ratings that is there in terms of which of these tools that have very active communities, because I do know that they are varied in terms of the communities, how active they are, so that they can very well inform the users when they are picking them. Thank you so very much.
Oh, I'm sorry, I was speaking on mute. Jose, you've got your hand up. Please go ahead.
Thank you, Steve. Sorry, I'm unable to turn on my video, but I hope you can hear me.
Yes.
Nice. So thank you, Steve. Thank you, Alvin. Alvin, I've been actually quoting you severally in some of the works that I do, and I'm happy to put the name on the face today. Other presenters also, I want to say thank you. That was very good, very insightful. Yeah, I just wanted to share my thoughts. It's not a question as such, Steve, but you know, what I've been thinking around these particular issues of digital public goods, especially in health sector. You see, yes, they are very good. I have seen OpenMRS implemented here in Kenya, and some of the facilities are using it, and it's working. However, there are some challenges that even as we are thinking of how to make sure that we use digital public goods for our benefit, there are some challenges that really still affecting most LMICs, and Kenya being one of them. Issues to do with you know, the technological infrastructure, issues to do with the capacity of the people who are actually expected to use these digital equipments. And this, I'm talking about human resources for health. We are talking about even issues to do with leadership within the health sector itself. And I know, Alvin, in one of your papers in 2018, actually, you mentioned this particular issue of leadership and governance being a serious issue that affects digital health. Issues to do with quality of data that, you know, is available in, you know, in this particular digital health or digital public goods. And because of that aspect of being poor in terms of quality, it even affects how it can be used to inform strategic decisions and other, you know, decisions going forward. So yes, in as much as we are thinking of how we can make sure that digital public goods are there working very well, some of these also challenges are some issues that need to be addressed. Over to you. Thank you.
Great. Thank you very much, Jose. I know we've literally run out of time at the top of the hour, but I think that's actually a very good sort of closing remark, I would say, because you're literally talking about the enabling environment for digital health. I think most of us might or might not be familiar with the building blocks for digital health. And I think the paper that Jose quoted from Dr. Alvin is very enlightening. And I think most countries we work in, both in the AIN region and the Helena region, that's really one of the pressing problems that we're trying to solve: leadership and governance. And I think if we can solve that, we'll definitely make a big leap forward. I think at this point, I'll probably turn it over back to Alvin to close out and also probably tell us about the next webinar series. Over to you, Alvin.
Thank you, Stephen, Dr. Chaminda, and Dr. Sylvia for your time. There were a lot of discussions in the thread. I think we should have another session soon. Let me discuss with Stephen because this is a partnership between Helena and AHIN. And I know that Dr. Chaminda and the Health Informatics Society of Sri Lanka also have some contributions to give also. So maybe next time Dr. Chaminda will be the one presenting for AHIN more on the work on OpenHIE that they're doing, and also in Helena, maybe Stephen, you can select somebody on your side. And always relate it back to sharing our pain points and our solutions. I hope that after this session, Stephen, we will summarize it. I will share it to you. Let's come up with a one-page output from this session and then make that our recommendation to our partners. If you want to learn more about our experience in OpenMRS, please just email me. It's not easy, but it's also not hard. What you need is a dedicated team with a long-term vision and a commitment. So as I said, a global digital public good together with a local competent workforce, I think is a very good combination. All right,
Okay,
thank you
thanks,
everyone.
Alvin.
All right, good night. Hi, Carl. Good to see you. We
Good night.
survived COVID. Bye, Carl.
Bye-bye.
Bye-bye.
Bye-bye. Good show, good show.
Yes, thank you very much, Alvin.
Thank you very much.
Very interesting.